For the next talk, this is really the highlight. I mean, for me, because I know what Marcel and Charles do. It's going to be Dr. Linda Gray and Dr. Peter Kranz. And I've known Linda for a long time, for like, I don't know, 15, 20 years. We've just been talking on the phone, and luckily, finally, this year, I got to meet her. And she's going to give a talk about current and evolving percutaneous treatment approaches, the Duke approach. I mean, as you all know, she's at Duke University Medical Center, and she has a fantastic, unlimited amount of knowledge about spinal fluid leaks. Thank you, Linda.
I'm always getting a little oversold. I'll just hope that I can show you something that maybe you haven't seen. So we have a little different practice at Duke in that we're all neuroradiologists, all four of us. I get to work with three really terrific guys. And we are actually kind of primary care neuroradiologists, I like to say, because we see the patients, we do the diagnostics, we do the treatment, and we follow them up. So we get to see the consequences of our actions, which is pretty interesting. And the patients will call us back when they're having problems, so we have to solve those problems. So in that way, we have a lot of longevity in terms of taking care of each individual patient. I have some patients that thankfully have stayed with me for 8 years because I just couldn't figure out the problem, and they still have the problem. And then as we go along, we learn more, and so a lot of those patients are getting better now because I've gotten smarter. So I'm going to talk to you in terms of the kinds of leaks that we take care of. We take care of all kinds of leaks. But I'm going to just kind of segue through what we do via ventral leaks, and then Peter's going to talk about some others. Oops, sorry. Okay, so let me just say one thing is that, fibrin glue injected in the epidural space actually is an off-label use. And we use it a little bit differently than Marcel does, and I'm going to explain that to you. And I have to just say that I feel like I'm always confused about this topic in general, but I feel like we are learning some. Oops, okay. So let's start out with a case. This was a 32-year-old woman, had positional headaches for several months. She had been seen at 4 different major medical centers in the Midwest. She had no upright time. Opening pressure at an outside institution was 4. She'd had a blind blood patch, temporary relief, and really no diagnosis. So when she came to me, she was just basically lying down. You can see that she has actually no MR findings of a leak, so I just want to tell you, like having a normal MR does not exclude a leak. And so just in looking at the imagings that she had from the outside, actually what she had was something that was missed, which is a tiny calcified disc, and adjacent to that, there it is on sagittal images. Adjacent to that is this extradural collection outside the thecal sac. So all I had to do was just plug that little space right there where the dural disc was, where the disc was penetrating the dura, and she, was a normal person then. So some of the things that we're looking for are incredibly small, which I think is really important to realize. So really having very high quality diagnostic imaging is really important. So who do we all know who have chronic headaches that we're just not getting better with our diagnoses and treatments? And there's a lot of misdiagnosis out there, I'm sure, as Wouter has addressed in the past. So what I want to show you today are our strategies for evaluating CSF leaks. And that would include optimized CT myelography. We do dynamic fluoroscopic myelograms when we need to. And sometimes we do interthecal GAD. In our particular case, we don't do the high-resolution MR scanning like they do at Cedars-Sinai. I don't know what to do with all that. So I'm going to also talk about the causes of ventral leaks that we have and then how we target and treat them. So the main thing is you have to you have to optimize for the kind of leak that you're looking at. So if you're looking, and Marcel addressed some of this, for a moderate to fast leak, generally we start out with just CT myelography. If it's a fast leak or a super fast leak, we're gonna do dynamic fluoromyelography or DSM as they do at Cedar. And then for slow leaks, we're gonna do something like MR myelography with intrathecal contrast, or super slow, or an intermittent leak, which can occur sometimes. You might think about doing a delayed CT or delayed MRI, and we really use nuclear medicine. We never use it except for like base of skull leaks sometimes. So some people do start with this standard or heavily T2 weighted image, but we just don't really do that. So let me just show you how we do this. So we do everything under CT guidance, all of our LPs, everything. So first of all, the patient's lying in a decubital fashion on the CT scanner table, and we do a scout, localize a level, and here's our patient right here, who's one of our CT techs who donated herself for this presentation, and we localize that level. Usually we'll go in at the L3-4 level. And we mark her for the lumbar puncture, and then we use always Gertie Marks needles, which are 24 gauge, side hole blunt tip needles. You have about a 1 in 1,000 chance of having a post-LP headache with that needle, which I think is really terrific because I hate to create a problem that I'm trying to treat. So we put in the Gertie Marks needles. We know that we're in a good location for getting an accurate pressure because sometimes people will come to us with really supposedly low pressures, but it's probably just been a sidewalled needle. So this way we know we're in the center of the canal getting an accurate pressure, and then we can do our myelogram at that time. Now we use ICView 300M to do this, but you know what? If you want to do an MR and a CT myelogram at the same time, you can put in ICView 300M and Magnavis, also an off-label use for that, but that's only a half cc of contrast, and then you can scan the patient with CT for the myelogram, and then you can send the patient to MR if you want to after that. Now, how do you get the contrast to move when you don't have a tilt table like you do in vascular? So what you can do, actually, it's pretty easy. Just put the patient's feet on the bolster that comes with the scanner, and they just lift their butt up in the air, one of our CT yoga positions, and you can just run the contrast right down. It goes right down the back of the thoracic spine. And then here, they just roll around, and a lot of times we have to help people do this because sometimes they're pretty debilitated. They're not always like in their 20s and really easily mobile, and you can just roll around on the scanner, and once you do this log roll, we wind up in the prone position, and we have a very fast, high-resolution scanner with, we get 2.5 millimeter thick sections through the entire spine, base of skull to sacrum, and then we re-render those at 0.625, so really high-resolution images, and then we do reformatted images with that. So let's talk about the kind of leaks that you can see. So iatrogenic, for sure, people have talked about that. I'm just going to show you some examples. And then spontaneous or traumatic leaks, and then discs. Discs are a big problem as far as causing CSF leaks, and I think underappreciated in some cases. So let's take a look at the iatrogenic ones first. This is a patient who actually came from the West Coast, who had an epidural catheter placed for delivery of her child, and she developed a ventral leak. And here is the ventral leak right here on the axial images and on the sagittal image, and then here as well. So an epidural catheter placed for delivery, creating a CSF leak in the ventral location. This was a patient, really big person, had a lumbar puncture, and unfortunately they went through the thecal sac, so she actually has a ventral leak due to that lumbar puncture. So, you know, a lot of times we're doing blood patches and they're over the back surface and they don't necessarily get around to the ventral surface. So those patches that you do on the dorsal surface are not necessarily going to catch these kind of leaks that are present. The way to do this and to approach those percutaneously is actually to go through a transforaminal approach, and you get kind of far lateral, and then you can go in here into the transforaminal region, and then you can get the contrast, and in this case we would use fibrin glue as well, into that center location, and you do it on both sides so that you get the glue and blood to go ventrally. Now, we use fibrin glue almost every single day, which would be Monday through Friday, and probably sometimes 3 or 4 times a day. So we use fibrin glue a lot. It's targeted. And we don't use the frozen stuff that, because you know what, when you use the frozen stuff, you need a bigger needle. We like to keep everything small, so we use 22 gauge needles, and we kind of wheedled out of the company how to actually make the fibrin glue not as sticky. So we actually make it ourselves so that it sets up in 2 minutes as opposed to 2 seconds, and it flows a lot better with blood. So we can actually get the fibrin glue to spread a little bit better in that regard. So this is the way that you would do a ventral approach, is just try and get that needle in the transforaminal region and really ventral in location. And then post-operatively, a lot of times after discectomies, patients can have CSF leaks. In this case, it came off of the nerve root sleeve after the discectomy, and you can approach that in several different ways, and we just went right through the post-operative site there to get that leak right along the transforaminal region there. Okay, spontaneous or traumatic leaks. This was a 46-year-old woman who came to me after 2 years of symptoms, and she actually had, was hospitalized after this. She had been doing boot camp classes and doing burpees, which, you know, I'm way beyond burpees, but she, you know, if you know what those burpee things are, you know, like up here, kick your feet out, I mean, it's brutal. I think you could probably do it though, Scott. And at any rate, she had a normal looking MRI and no dural enhancement whatsoever. The interesting thing about her is her opening pressure was 31.2. We almost didn't even do a myelogram on her, but we said, you know, she can't sit up, she was hospitalized, you know, we're just gonna look for a leak. And damn, if she didn't have a leak here, just ventral to the thecal sac, and that was at the thoracolumbar level right there. So we were really surprised to see that. In order to treat that, we would use fibrin glue and blood, and we just went in and targeted that through the transforaminal region and then put in fibrin glue and blood, and she just needed 1 patch, and that was it. Fast leaks. So this is what Marcel would do like digital subtraction for, but let me just show you some examples here. This is a patient who actually was a neurology stroke fellow. I love it when I get to take care of neurology people who can actually learn then about intracranial hypotension. And she was at a meeting and actually developed a terrible headache at the meeting. She's only 35 years old. And she had this calcified disc that was present right here, and these little whiskers, there's the calcified disc, and then on either side are little whiskers of CSF leak that are present ventral to the thecal sac. We patched her, it just didn't last. And when you have something like a calcified disc like this penetrating the dura, you're just not gonna be able to solve that just with a patch. Occasionally I have, but not always. And so here we tried ventrally patching it again, just through the transforaminal region. You can see the contrast here going ventral to the thecal sac. And you know what? I had to send that patient out here to the West Coast. And so Wooder took care of this patient and took down that calcified disc, and here are the images that he sent to me of that patient. So calcified disc on either side penetrating that dura. When you have a really diffuse leak, as in this particular case, and the contrast is all outside of the thecal sac. So you can see I circled the normal thecal sac. Everything out here is outside the normal thecal sac. And when you have a really diffuse leak like that, you have to do something faster to pick up the location. And this is where DSM would come in, or we can do just conventional myelography as well and catch that leak. This patient was a 51-year-old with a 2-year history of positional headaches that started abruptly, no inciting event. She's got leaks outside. She's got the obvious findings of dural enhancement, subdural fluid, and you can see this collection outside of the thecal sac. So what she had was 2 discs, and so when you have 2 discs, you would normally expect that it would be the disc that is actually the bigger disc. So here are her 2 discs right there. There's 1 disc and there's a tinier disc. So Peter did this myelogram on her, and actually the leak, which you can see right here, is actually from the smaller disc. And so in this case, the leak originated at the smaller disc. We can target that site with fibrin glue and blood and confirm that that's the problem. And then if she doesn't get better, then we can always send her to surgery. And generally speaking, we'll patch somebody twice when they have something like this. And then if that doesn't work out, then we're going to send them to surgery. This is just, Marcel could have shown this case, but this is a calcified disc here and digital subtraction showing a really fast leak. So you kind of have to tailor the imaging that you're going to do to what you find the rate of speed of the leak to be. Okay, so let's talk about intermittent or slower leaks. And this was a guy who came in from playing golf at 53 years of age and gradually had a downward slope. So all of you golfers out there, I'd just be slightly wary, okay? So this patient has terrible downward herniation. The mammillary bodies, you can hardly separate them actually from the pons. You can see he's got a crumpled up quadrigeminal plate and total downward herniation. His perimesencephalic cistern here is totally effaced. He had no memory. He actually could not control his bowel and bladder. He had a drool rag because he couldn't control his own secretions, and he had a gastric tube because he couldn't get any nutrition. So what was the etiology here? So he had tons of degenerative changes here, and he had this disc that was located ventrally. The first time I patched him, he had 5 days of being a normal person, and then we kept working to get back to those 5 days after that. He had no leak that we could see on the myelogram, so this is a guy that we did MR myelography and where I learned that discs can really cause these problems. And here is the disc right here and the contrast leaking out on the side underneath that disc and going into the neuroexit foramen. So then I also learned that really bad facet arthropathy dorsal to the spine can also cause leaks in that location as well. So nothing seen on the CT myelo, but we could see it on the MR myelo. This patient is 55 years old, and I had to work with this guy for several years in order to get him better. He had double vision, blurry vision, he had no memory, he didn't know who the president was, he was sleeping 18 hours a day, and he couldn't drive or anything, couldn't even add 2 + 2. And you can see he's got this kind of dementia-looking brain, but what it really is just downward herniation from a terrible CSF leak. From 2012 to 2016, he just progressively got worse despite the fact that I would patch him. And on myelogram, he had only one thing, which was a very small disc at the T2-3 level. And we did an MR myelogram on him, and it just didn't help. I could not see anything that was really leaking underneath that. So what do we do? So I actually targeted that patch. He would get better for about 3 weeks, but it just wouldn't last. So I sent him to surgery, and he did well for about 6 weeks post-surgery, and then he started to slide. And so then we re-imaged him. It looked like the disc had gotten better or bigger, and here's the disc previously and then the disc afterwards, and now you can see that there's some deviation of the spinal cord. And so basically finally we got him another surgery, and now his brain has actually moved back up into his head, and he can drive and he can add 2 + 2, and so he's like a totally normal person now, which is really great. So, improved after treating that. Now, the key thing about this is that there are going to be places where you are not going to see a leak, and the patient's got a brain that looks like this. So what we do, or what I do, is I look for areas which I think are potential sites of leak. And then I do a percutaneous fibrin glue and blood patch at that site and see what kind of results I get from that. And then that helps me diagnostically figure out whether that's the site, and then if the patient's not getting better, I can send them to surgery at that site. So what are the treatments for CSF leak? Used to be bed rest, caffeine, fluids, lie around for a year or two until you get better. And now, thankfully, we're intervening more on this, and so now we're doing blood and fibrin glue. And I would have to say we use fibrin glue a lot, particularly in bony locations. We do sometimes do non-targeted patches because I have some young women who I can't see anything on, but they have really positional headaches. And in that case, we usually do sort of a non-targeted patch at the T11-12 level. Otherwise, we are really trying to figure out where the site of leak is, and so we tend to do more targeted leaks. The patients actually come to us a lot of times already having multiple blood patches that are non-targeted, so we try and improve on that. And then ultimately, sometimes we send people to surgery. So in the setting of headache, I think that in general, ask yourself the question, is this a pressure-related problem? And then how should you work it up from there? Well, brain MRI and contrast totally is got to be your starting point. And remember that normal imaging and pressure do not exclude a CSF leak, and high pressure does not exclude a CSF leak. So, do you think you might have a leak? Okay, so what are we going to do? You could do the spinal MRI and just do that and see if you see anything. If you do see something on the spinal MRI, it's generally going to be a fast leak, so you can help target where you're going to go from there. We do lumbar puncture and pressure and then CT myelo, that's our starting point. If it's positive for a leak, if you can really define the leak, then you could target it with blood and fibrin glue, and we'll generally do it twice depending on what we're finding, and then if it fails after 2 times, we'll send them to surgery. If you see the leak and you can't define the location, then a dynamic myelo or DSM is going to be very helpful. And then let's say you don't see a leak at all. Well, you could go to a non-targeted patch, and we will target at this point what we think is the most likely site of leak. And the other things you might do if you're trying to really find it is maybe do a delayed myelo-CT or a gadolinium myelo-CT in order to try and find a leak that you can't see any other way. So with that, I'm going to turn it over to Peter, who is going to talk about some other things that we treat besides ventral leaks. Okay, Peter.
Okay, so I would be remiss if I didn't thank Linda, who got me into this mess about 10 years ago. I sort of see myself as like the Sancho Panza to her Don Quixote, except it turns out that the windmills actually are real giants in this case, so it's not all entirely hallucinations. But I'm going to be talking about, I think that a big problem in the realm of treatment is not just how to treat, not just the technique of how to treat, but deciding what to treat. So, and I think that things have really changed over the past couple years with the discovery of CSF to venous fistulas. I think that's a really important development, so I wanted to talk briefly about that, and then say a word or two about, I think, where we need to be going. So, so I remember I was having a conversation on the phone with Dr. Sheving several years ago, and I said, I've got this guy, and he's got this sort of leak, and it kind of looks like it's going into a blood vessel. Have you ever seen anything like that? And he said, it's funny you should say that because we just submitted this paper where we saw these 3 people who have CSF to venous fistulas. And I thought, oh, well, that's really interesting because, here are people who have symptoms of intracranial hypotension and don't have a leak on their myelogram, but now there's something objective that is being found that might explain their symptoms. And that was the first case I saw was in 2013. The next case I saw was maybe, 9 months later. In the past month, I've seen 3 new cases of this. And so this is something that was probably always there. We weren't looking for it, and now we're finding it a lot more frequently. So this was that case I was telling you. This is like a 50-something-year-old truck driver, and he had this image on his myelogram, and I thought this was like a little low-flow CSF leak, right? So I patched him there a couple times. He had subdural hematomas. He wasn't getting better. He was in the ICU. I finally said to one of the surgeons, listen, can you go in and operate on this guy? And he said, okay, well, he's pretty sick, so we'll go ahead and do that. And he said, after he got out of the operating room, I said, well, did you see the leak? He said, no, I didn't see a leak. There were some funny-looking blood vessels around there that I, just kind of bipolared. And the next day, the guy went home and never had a headache again. And I called him 2 years later, and he was like, that's a closed chapter in my life. That never, that I feel totally normal. So then, going back and looking at this is that same level, but it's just kind of reformatted. And what I noticed was that there's actually this high-density sort of line, which is going off into where you would expect a segmental paraspinal vein to be. We sort of looked at this with some color-coded overlay. It just makes it a little more conspicuous that there's this high density here. And this is actually myelographic contrast in the CSF space, which is now in a vein. Okay, so this is one of the things that I like about the fact that people do things differently at different institutions is that it lets us look at the same problem from multiple different angles. So this is like the CT look at the CSF venous fistula that the Cedars folks found on digital subtraction myelogram. And you can see this is a coronal image, and you can see this is the vein, which is going away from you. And at none of the other levels did you have a really high density vein like that. So we talked about this, the hyperdense paraspinal vein sign. We found 3 cases, and then we just started finding a bunch more. So I'll just show you a couple examples. So here's a case where this person's got this big muscular branch on a coronal reformatted image. You can see it's kind of got this loop. It runs back up behind the transverse process. And then on a dynamic myelogram, which is just a myelogram done with the patient in lateral decubitus, and you can slowly let the contrast bolus get up over there and really let it sit over top of the suspected leak site. You can see this fine reticular network of blood vessels that, dynamically you could see would sort of wash in and wash out and wash in and wash out. So just another example of a CSF to venous fistula. Here's another case. You can see there are these, this big diverticulum here, and these paraspinal veins that are leading off along the edge of the vertebral body, and some that are actually going through the venous plexus of the vertebral body. And we looked at the CSF venous fistulas that we found, and about 80% of them had a diverticulum associated with them. So I think there's some element of relationship there. I don't know exactly what that means yet, but this is the same case on a sagittal image. So you're looking at a sagittal image through the level of the neural foramina, and you can see this diverticulum. You can see this hyperdense paraspinal vein leading off, draining anteriorly to the spinal column, and you can see a bunch of other veins at other levels which are not hyperdense. And we found that 70 Hounsfield units for the radiologists in the crowd is a good cutoff value. If it's above that, it's pretty reliable that that's a fistula. So it changes the way I looked at the studies now. I look once looking for a leak, a conventional leak, a high flow leak, and then I really change my windows up and I go back and I look. And like Linda said, the thin section images are incredibly valuable. I mean, I wouldn't go back to doing anything other than these sub-millimeter images now. And this is the same appearance on the dynamic myelogram. It sort of replicates, I think, what you kind of see in the digital subtraction myelogram. Interestingly, this case is one, this patient was a little obliqued, because if you look at where this goes, the vein was actually hidden behind the diverticulum on the AP projection. So just looking AP, you couldn't see the fistula. And it wasn't until, I could sort of rotate the patient out a little bit more that you could see the vein wrapping around the waist of that vertebral body. So there's the little vein. Here's just another case. Again, you can see this big paraspinal vein filling on the CT, and you'll notice that this was done with the patient in lateral decubitus, so that's why there's contrast layering on this side of the thecal sac. Because we found that when we suspect that there's a CSF to venous fistula, I'll take the patient, I'll do the myelogram, and then I'll leave them in the decubitus position. So all that dense contrast is sitting right over top of where I want it to be, and I think that enhances the visualization. Here's the little vein coming off of the top of the diverticulum on the dynamic myelo. This is another very interesting case. You know, I saw this. I didn't know what that was. I thought it was a leak, but that's in the epidural, the internal epidural venous plexus. That's contrast in the internal epidural venous plexus. And here's the dynamic myelogram. You can see this really funky looking nerve root sleeve, but then there's actually this little reticular network of blood vessels centrally, and also this big vein out here laterally, which was a level above. And again, it would sort of fill and then wash out and fill and then wash out. This is a case who, I think this is the patient I saw about 2 weeks ago. Okay, and so on the dynamic myelogram, there was this really funky looking thing in this area that had this small reticular blood vessel coming off to the side. I really wasn't too sure what I was looking at there. Took her to CT, and you can see there's all these these small channels connecting this area. Actually, a bunch of diverticula at multiple other levels. This was like the one level without a big diverticulum. It has this small sort of funny round structure. But when we did the post-myelo CT, now you can see this big vein that's actually draining off to the azygos vein here, running in the paraspinal space, and this is the CSF to venous fistula. And again, I kept this person in lateral decubitus to really maximize the filling of that blood vessel. This is just another look at the sagittal image. You can see the big diverticula above and below, but this sort of reticular, funny-looking, wispy lines, that was actually the side of the fistula. And again, you know, when you come out a little bit further lateral on the sagittal image, you can see this hyperdense vein, which is draining into the azygos. Now, just to show you what this looks like, here's a movie. These are just the axial images, okay? So let me play that again. You'll see the vein off here on the side. As I slide back and forth, you can see what that looks like. And, you know, I'm sure that this was present on myelograms in past years, and we just, you know, the mind sees, the eye sees what the mind knows. So we weren't looking for it, and we didn't see it. Now, this is interesting. This is the same patient, and I scanned the patient in the lateral decubitus, and that's the image on the left. And then I rolled the patient, you know, to distribute the contrast as you would normally for a myelogram, and scanned her immediately. Like, you know, these images were taken like a minute apart. And now you can't see that fistula anymore. So I think that, you know, these things are fickle. They're fickle, and they are difficult to track down sometimes. And we got to figure out how to tease out the best way to see them. I patched this patient. This is just to show you what that looks like. This is a CT fluoro-guided patch. And you can see the needle coming in through the transforaminal region. And the bright white stuff is the contrast going in, and you can see it wrapping circumferentially around the thecal sac there. And she got wicked high pressure afterwards and was in the hospital for a day and is actually doing pretty well now. But these people do tend to get pretty high pressure. So, okay, so that's the little bit on CSF to venous fistulas, and this is one slide I'll try to go quickly. I think, you know, in terms of what's next, I think, you know, paradoxically, the biggest challenge in treatment is in improving diagnosis, because you have to know who to treat and what to treat, and that is not always a trivial challenge, and who's going to benefit and who's not going to benefit. And that, as Dr. Levin was saying earlier, you know, classification is important. So you want to have really good diagnostic criteria that capture as many people as possible, but don't over-capture. We don't currently have quantification of positionality at all. I mean, when I have a headache, I feel better when I lay down. I haven't let Linda patch me yet. But you know, there's some gradient there of who feels better when they lay down, and and what does that mean? And then we've got to do a better job with tracking outcomes in a prospective way, because just going back and looking and say, well, you know, we look back at 50 cases and, you know, everybody got better. That's actually, there's probably a lot of detail there that we're missing. So I think that's really important for what's coming next. And even though that's not exactly treatment, it really, I think, you know, once you've been doing this for a while, you realize that deciding what to do is, and who to treat and how to treat them is as important as, you know, actually the skills in putting a needle in and injecting something. So that's it for me, and I'm going to turn the podium over to the next speaker.